Need the mic. Just a second. Teresa, thank you.
Hi. Well, thank you very much, all of you. My name is Teresa. I'm not a doctor. I'm a patient. I'm a mother after breast cancer. He's 5 years old now. And I think what you're doing is amazing. I just wanted to, as a patient that I am, and I really appreciate the picture by Octavi showing all of us. I would just like to emphasize the fact that we take our own decisions. I mean, you've been talking about chemotherapy, radiotherapy, tamoxifen. Sometimes we decide not to take tamoxifen. And guys, you need to be ready for that. Because that's powerful and it happens a lot. And I've even seen studies where they talk about how many women abandon tamoxifen. The rate is really high. I don't know why people don't talk about that as much as they should, because that will of becoming a mother is so strong that we even want to decide against our doctor's opinion sometimes. So thank you.
May I just comment on this comment, because this is very, very important. When we decided to, make the positive study that Octavi presented, it was exactly because of this. So we knew that in the real world, women stopped the treatment because they wanted a baby. And the time to pregnancy in all the studies that Octavi presented you is not 5 years, also for the ER-positive patients. So this means exactly what you are saying. The point is that the tamoxifen or anyhow endocrine treatment is very important for young women with ER-positive breast cancer. So the aim is not to avoid pregnancy, but to avoid to have a shorter treatment with an effective drug, which is tamoxifen or aromatase inhibitors. And so that's why in the positive study, women are allowed, because we don't allow anything. I mean, women decide, as you say, so they take their own responsibility. But, they may stop the treatment after 18 to 30 months, because that's reasonable in terms of protection from the endocrine treatment. But then they are encouraged to start again the endocrine treatment. And the let's say, first aim of the study is really to see if this kind of stop-and-go treatment, so strategy, so you stop the tamoxifen, then you restart the tamoxifen, is as effective as the 5-year continuous or the 10-year continuous. Because you're right, this is one of the main issues for young women with ER-positive tumors. Those are a little bit more difficult patients because we know of the compliance issue. We know that prognosis sometimes can be a little bit less favorable comparing to the triple negative, for example. The young triple negative have the same prognosis as the older triple negative. The very young endocrine responsive patients that have endocrine responsive tumors fare a little bit worse compared to their older counterparts. So this is very important, again, stresses the importance of communication between the doctors and the patients. Thank you for your comment.
Related to this commentary, Teresa, and what Dr. Mathews called tamoxifen holiday, I think it's more or less the same feeling. Anyway, we need to understand from our point of view that for the last 20 years, we've been reducing treatment. So we're not doing mastectomies, we're not doing lymphadenectomies, we're not giving chemotherapy to those low-risk oncotype or mammoprint low-risk groups. We're not giving axillary radiotherapy to those patients with 1-3 positive nodes. We are reducing treatment in luminal A patients. So if finally the only treatment is tamoxifen, please understand that we might need to do it. Or probably we would have given chemotherapy, mastectomy, radiotherapy to those patients. So we've been able to reduce recurrence, and now we're having recurrence after 14, 15, and even 20 years. When we started, we have them 6 months, 2 years. So we've been able to do that, reducing the aggressivity of treatment. But when tamoxifen is the only weapon that we're using, just taking a tamoxifen vacation might be dangerous. So I think that the point, or one of the point of this meeting, is how do we counsel patients about safety? And of course we can say, oh, it's safe. Well, it's safe depending on what you need to treat your cancer. And if tamoxifen is the only treatment that we're giving you, well, of course, we have some calculators that might help us telling you if you do not take tamoxifen, your recurrence risk might increase 10%, 20% at 5 years. But you're looking for a baby. You want us to tell you about recurrence in 20 years. You don't want to know your risk of death in 5 years because you're planning to have a baby. So I think that from this point of view, patients have the right to stop taking tamoxifen, but we do have the right not to accept them for IVF treatment for the same reason. So I think this is an important point of view, and I'd love to have the point of view of Octavi and Fedro about this specific subject.
Well, you already know, Teresa, we already met us. You already know that I absolutely agree with you. Empowering patients, it's taking a central role in our nowadays concept of medicine. We are changing our point of views from a paternalist medicine to a giving a decision between patient and doctor. So what we have to do is it's to inform the evidence that we have, and as leaderships on this topic, we have to inform to our colleagues. We have to give this information not to allow a pregnancy, just to inform to our patients that where are the evidence, and take a decision altogether between patients and doctor. That's my point of view.
Yeah, I also want to make a comment because Octavi went very well into all the conundrums of how pregnancy might influence breast cancer prognosis. As a matter of fact, all our curves of pregnant women after diagnosis of cancer are a little bit better. When we wrote together the paper on JCO on ER-positive breast cancer patients who had a pregnancy, actually the curves were better for the patients who had a pregnancy. And the reviewers did not allow us to write that it was better. So they say that it was not worse, because there is always this concern that it might be a selected population, it's the healthy mother effect, the fact that maybe you can overstage the patient that undergo a pregnancy because you want to be sure that they don't have disease when they start the pregnancy. So all these issues are right. But if you have looked at the forest plot analysis on the meta-analysis that we also did a few years ago, and there's been, there are many other evidences that just goes in the same direction. So I think that there is something on the pregnancy after cancer that changes maybe the local milieu, maybe as Octavi said, it's a matter of immunity, it's a matter of microchimerism, it's maybe the different hormonal milieu, maybe it's just psychology because mothers, fight for their baby and they find resource and resilience to fight also with the cancer that was something in the past, but it still, remains in their heads, in the heads of many women. So I think that it's still very important to study the biology of cancer in women who have cancer during pregnancy, and also women who had pregnancy after cancer, just to understand a little bit better about that. But I agree, of course, that endocrine treatment, it's a pillar of the treatment of endocrine responsive breast cancer. So we cannot make discounts. We can maybe, think of how to put the things together as in the positive study. And I think that the tamoxifen holiday has some reasons. We know that there is a carryover effect for tamoxifen, so that you are protected also for a couple of years after you interrupt the tamoxifen. So I don't think that we will find from the positive studies, bad results. I don't expect, actually, that patients who stop the treatment for having a pregnancy and then restart the treatment have worse results. I hope they have even better results, but we will see.
Yes.
Can I just say that on a sort of quite a small group of patients, the ones who are BRCA positive and hormone receptor positive, which is the smaller percentage of the BRCA positive patients, there is always the option. It's less favourable, but they may opt for surrogacy. And I certainly have one patient who felt more comfortable opting for a surrogate rather than becoming pregnant herself and interrupting her therapy. So although it's not something that's discussed very much and it's not the ideal, there are alternative ways to build your family as well. So we can't forget about that.
Yeah, that's a very good point. Unfortunately, surrogacy, for example, is not legal everywhere in Europe. In Italy, it's really illegal. So if you go to jail, so you cannot do that.
Yeah.
And but you're right. I mean, parenthood is not just having babies. It's also adoption. It's also surrogacy. It's also just accepting the fact that you cannot have babies. Of course, I mean, we shouldn't say this here, but life goes on also without children. It's not that it's mandatory to have a lot of babies. But anyhow, I think that this should come into the counseling. And you're right, for the BRCA mutation carriers, our group, Matteo presented at ASCO the results of the pregnancy after breast cancer in BRCA carriers. And fortunately, the results are as good as in the non-BRCA carrier population. The BRCA2, you're right, it's always a more difficult patient population because they have ER positive and probably the effect of pregnancy is a little bit different, also in terms of healthy BRCA carriers. But the take-home message is that also in BRCA carriers, pregnancy after breast cancer is not dangerous, and it's a very important message. New message.
Any other question before the coffee break? Please, Isabella.
Thank you very much for all of you for your excellent talk. I would like just to come back to the issue of BRCA mutated patients, because we have an increasing phenomenon of patients who come before having cancer to cryopreserve the oocyte because they have been diagnosed with BRCA mutation due to family history of cancer, and they come to cryopreserve the eggs or do pre-implantation diagnosis if they want to get pregnancy. And actually we don't have any, to my knowledge, any data on ART before having cancer in this population. And so I was wondering what is your opinion about the type of stimulation we should do to this patient? Do we have to add letrozole or not? Actually now we don't, but I don't know, just to have an opinion.
I don't know either. But what I do know is that with letrozole, I don't get significantly less furosemide, so I'm quite happy to put a bit of letrozole in if I think it might reduce the risk. So on a practical level, that's what I would do.
Yeah. Well, we have few data about the use of ART in healthy BRCA carriers, apart from the data of the lower ovarian reserve, so the less numbers of oocytes that you can gather, particularly for BRCA1 and apparently not for BRCA2, again, a difference in the two type of mutations. So I don't think it's really a safety issue, so I don't think it's unsafe to collect eggs at early age in healthy BRCA mutation carriers. On the other And I think it's a very good idea, because if you wait for the cancer, of course, there are all the issues that are time, that are, the stress related to the cancer diagnosis, and the, practical impossibility to do more than one harvest, or at least to do 2 harvests, but not more than 2. So if you really want to go for the PGD, so if you really wanted to select the embryos that are not affected, you should have a lot of embryos. And to have a lot of embryos, you have to have a lot of eggs, of good quality eggs. And to have good quality eggs, you have to harvest eggs before the disease, around the 30s. And so when we see patients that are BRCA mutation carriers, and they are healthy, and they are, dealing with all the difficult choices, will I have a baby? When will I have a baby? We tell them that if they don't have, for example, a partner, and they don't plan a pregnancy, which is quite early pregnancy, because of course there is also the issue of oophorectomy, so the bilateral adenectomy. So we suggest patients to go for egg harvesting, and we use letrozole also. Well, we don't use because we don't do IVF, but we suggest, we consider letrozole, just because it's what we have as more experience in breast cancer. So that's just.
Well, I think that the other thing that might bother us, and Octavi said it a few minutes ago, is they're supposed to be, most of them, hormonal negative tumors that are going to appear in these BRCA patients. But are we sure that any hormonal stimulus won't give us a risk for breast cancer in these supposed to be negative, hormone negative tumors? Well, I think we do all agree that we do not have an answer to this question. So maybe we might feel more comfortable with letrozole, but I think we all doing IVF treatments with standard gonadotropins. And I think that the only important thing is to make sure that we are collecting this data and maybe publish it as retrospective studies to get more evidence in an area where there's no guidelines and no law. But having no law doesn't mean that we can do whatever we want to do. I think that we need to do it in specialized units and, of course, share and publish all this data. I think it's important. There was another question? Oh, yeah.
No,
Dr.
just
Cusido.
a comment according to the BRCA mutation. I'm Maite Cusido. I'm gynecol-on-call. I'm not reproductive doctor. And in these cases, I agree with Dr.
Peccatori.
Peccatori. And I encourage my BRCA mutation patients to do a preservation of the fertility, because they need so many oocytes, because they have less reserve, and they need double number of oocytes if they want to do PGD. But I think that all this has to be in a big counseling, no? Because more of these women want to do preventive mastectomy, and probably you feel safe if the patient has been done previous mastectomy, and then you make the stimulation of the ovary, than the patient that doesn't have it done. So it's it's bigger, the concern for these women, I think.
For sure.
Yeah.
I mean.
Any other question before coffee break, or just go for it? Then let's go for coffee break. Thank you all.
Thank you.
Yeah.